Hi, I'm Dr. Michael Sprintz, and today I'm here to talk with you about pain and substance use disorders, protecting patients and protecting providers. I'm going to start with sort of a background on myself. I'm originally trained as an anesthesiologist. I'm also fellowship trained in pain medicine. I'm board certified in pain medicine, addiction medicine, as well as anesthesiology. Additionally, I myself have personally been in recovery for over 23 years, so I have a perspective from both a physician as well as from a patient. As far as financial disclosures, I do a lot of consulting, so there are all of my disclosures. So what are we going to talk about today? Well, today we're going to talk about the challenges that we have when identifying substance use disorders in chronic pain patients. We're going to look at how to identify warning signs and indicators of what's going on in terms of a patient who may have a substance use disorder. And we're going to discuss ways of managing the substance use disorders in chronic pain patients. So when we're talking about the intersection of chronic pain and addiction, it's important to recognize that this whole field is evolving and emerging right now. And so when we talk about evidence-based practices, I'll be talking about as the best evidence that we have at the time. But in the absence of the double-blind, placebo-controlled study from a major institution, we're going to be talking about, or I will be speaking about, my own personal and professional experience and those of my colleagues around us. So, welcome to the practice of medicine. Let's give some context. The reality is, it really sucks to be a chronic pain patient, and it really sucks to have an addictive disease. But when you have to manage both chronic pain and addiction in the same patient, it really sucks, especially when you were never trained for that. So the reality is, whether you like it or not, the field of pain medicine and addiction medicine are converging. It can't be avoided. In the shadow of the opioid epidemic, which is really a substance abuse epidemic, we have the fields are converging, meaning that pain doctors or any provider who's treating pain needs to understand the basics of addiction medicine. And for those who are treating patients with substance use disorders, they need to understand the basics of pain medicine. Because the reality is the overlap is immense, and you can't avoid it. So many times in the past, I've heard people say, oh, well, I don't have any addiction patients in my pain practice, or I just kicked them out. Well, the reality is you don't really know who is and who isn't. Yeah, there's the ones that are black and white is really clear in terms of someone who's at the end of their addictive disease and they're robbing people and they've got needle marks and all that. Yeah, okay, that's pretty obvious. But the reality is the most of our patients who have a substance use disorder or who are at risk for substance use disorder in the chronic pain population, it's all gray, it's subtle, it's nuanced. So that's a really important thing to recognize. Yeah, but if I undertreat my patient's pain, I can get in trouble. Damn you, Press Ganey. And I'm referencing the Press Ganey scores that you get patient satisfaction scores, and it actually hits the pain docs and the pediatricians the worst for not prescribing. But then we also have the same problem of, well, if I prescribe too much, I might lose my license and go to jail. So those are real concerns. And the reality is, as healthcare providers, we care, but we don't have enough time, right? And so as we're in this situation in healthcare right now, where as reimbursement decreases, the total number of patients we have to see per day increases, which means the amount of time we can spend with a patient decreases. And with complex patients, such as those with chronic pain and substance use disorders, having very little time to really catch nuances and subtle signs is really challenging. Now, we have the other problem, though, is that, well, not only do I not have enough time, but no one ever trained me in addiction medicine. I didn't know, and I never learned any of those principles. And these patients are complex, and they know their disease better than I do, and they're manipulative, and they're smart, and they're resourceful, and yeah, all of those things are true. And so these are challenges. It's a precarious balancing act. I want to manage my patient's pain, which sometimes may include opioids and other medicines that can be abused, but I also want to, prevent and decrease my risks and my patient's risks of abuse, of addiction, and diversion, right? So it's not always patients who have a substance use disorder. Sometimes it's patients who could be professional drug dealers, and they divert a lot of these drugs to the black market. So the reality is, more patients than you realize have a problem, have a substance use problem. And as much as we may not want to see it, you can't ignore it. It's here. And for those who are healthcare providers that deal with addiction patients, avoiding patients who have addiction and also have chronic pain, you can't avoid it. It's impossible. And ignoring them isn't, one, it's not good patient care. That's the bottom line. And two, you're not helping the patient, you're not helping yourself, and you're not helping the problem. And we all went into the healing and the helping professions to try and do good to help patients, and this is part of that. Dude, I'd hate to have your patience. So this is a direct quote from a colleague of mine another pain physician, when we were talking about my practice. So I have a clinical practice that since 2013 I founded the Sprintz Center for Pain and Recovery in the Woodlands, and it specializes in managing patients with chronic pain with or without substance use disorders. So we manage patients all the way up to and including those with the substance use disorder. And a colleague of mine who is a pain physician said, dude, I'd hate to have your patients. And I looked at them and I said, well, we have the same patients. I just manage them differently. And that's really important to understand. If you practice chronic pain management, and not necessarily, you don't have to be a full-time pain management physician. A lot of pain management is managed by primary care physicians and healthcare providers. If you manage patients with chronic pain, you have more patients in your practice somewhere in the spectrum of a substance use disorder than you realize. So, medicine has changed a lot, and especially since about 2015, I think in 2017 is when it really hit the mainstream, the opioid overdose epidemic. But what we're dealing with now is the challenges and struggles in addressing these patients. And we bump up against a lot of challenges in that. So one, we've got societal stigma against addicts. People in their active addiction do bad things, and people do get hurt. That's just a fact. And so some people have had really negative experiences with people who have substance use disorders. So for instance, if I was a kid, and this is just an example that I'm making up. Well, I was a kid, and my dad beat me, and he was an alcoholic, and therefore all alcoholics are bad. And alcoholics and addicts do hurt people, but it's the trauma that can occur to people that are in their lives, and that when those people grow up, they have biases and there's stigma. There's also stigma against pain management doctors. I remember when I first started out in practice, and I would walk around and be like, hi, I specialize in pain management, and they're like, oh, you're the pill guy. And medications is one part of managing pain, but there's this whole comprehensive ways. But the pill mills, and many of the pill mills, those providers who were writing scripts for cash, which was really, it was drug dealing. Those providers, that shadow cast over all pain management physicians. And so that's an important thing to recognize, that even pain management docs have a bad reputation as well. Then there's the pressure to relieve pain. Years ago, and I think it was near 2011, Institute of Medicine came out with a statement saying pain was the fifth vital sign, and we had a responsibility to treat pain across the board. And that really pushed in the era of a lot of opioid prescribing, because people were being rated on how well they managed pain. The Institute of Medicine has since taken that back, and obviously the consequences of that is part of the whole problem with the opioid epidemic. But those things have changed. And fear of losing licensure for treating pain. There's fear of lawsuits. Anyone who's practiced pain management for a while has been threatened by a patient to report us to the board or to report us to someone for not prescribing medications. And then you've got less time to engage with our patients, pressure with declining reimbursements, which I spoke about earlier. And really, there's not been a very clear consensus in the past on how to manage these patients. And that's part of why you're sitting here watching this webinar today, is to learn about, well, what is going on out there? What are some clear guidelines? And although we don't have there's not a clear consensus among both the pain management and the addiction medicine specialty societies that have said exactly this is how you do it. But we're moving in that direction. And that's one of the things that I'm a big proponent of, is really getting to this point where the specialty societies are now communicating together in terms of coming up with basic management guidelines that go beyond just not prescribing opioids to patients. And I also like to be clear that for myself, and it's important to realize that opioids, when used appropriately in appropriate patients, are good medicines. Just like a lot of other medicines. It's when medicines are used inappropriately or with inappropriate patients that we have those problems. So when you have a patient that comes in and they've got chronic pain and with a history of substance abuse, or you think they may have a substance abuse problem, there's this feeling that many providers get and have shared of like, oh no, here comes that patient. And yes, that's one way of looking at it. But there's another way. And it really all comes down to your perspective. Most of the healthcare providers out there, you haven't been trained on it. But these are the things like this webinar of where you're learning about it. So you can either view it as a problem or an opportunity. There can be denial, meaning that I don't have any of these patients in my practice, or self-awareness. Hey, look, I do have these patients in my practice. And I'm trying to figure out which ones have an issue and which ones don't. And that's challenging. There's uncertainty and versus competence, where I don't know how to necessarily manage these patients well because I was never trained. And as healthcare providers, I know for myself, when I was in my medical training and my residency training, it was this pressure to be right all the time. And I'm here to tell you, we're not going to be right all the time. It's not realistic, and that's okay. So being aware of that gives you some room to learn, because we avoid something if we can't be perfect at it. And what I'm telling you is it's okay not to be perfect, but we need to move in that direction. Fakeness versus authenticity. Again, if I fake like I know it all and I know how to manage these patients, that creates distance and a wall between me and my patients. Being authentic with our patients builds trust, and that's really important for healing. Walls versus connections. Again, it comes down to the physician-patient relationship. And I want to acknowledge and recognize that the way that the healthcare system currently is makes it really, really hard for us as healthcare providers to have a relationship and a connection with our patients like we've always imagined, and how for some of us had in the beginnings of our careers. And then stagnation versus growth. Just because we finished our training doesn't mean we stop growing and stop learning. Medicine is moving fast. Even the developments in medicine are moving fast. It's about growth. If you don't grow, you're going to wither. So let's talk about, well, what's your part in all of this? And I bring that up because if we don't look at ourselves and if we don't look at our own part in this, we don't grow and we're not able to show up in a way that helps both us and our patients. So one of the things to remember is recognize our own implicit biases. These are biases that came to us from how we grew up, from the area and the country which we live, from whatever cultural and societal and familial biases and prejudices that we have. And I say this in that it's neither good nor bad, it's just important to recognize that it's there. So acknowledging a patient's past negative experiences in the healthcare system. I don't know a patient who has been through this healthcare system and never had a negative experience. It's really hard to navigate the healthcare system. And especially if you're a chronic pain patient, and which means you've had pain chronically for a while, it means you've seen a number of doctors, you've been through the healthcare system for a while, and most patients with chronic pain have either been judged or accused of having a substance use problem, or have been treated negatively or dismissed or invalidated as far as their pain conditions and what they were experiencing. So as a patient comes and sits down in your office, you have to recognize that they've already been through the healthcare system for a long period of time. And most patients don't have a strong advocate to help them. So it's normal for them to be guarded about how they come and present to you as a healthcare provider because they've already had such negative experiences. So that impacts how they view you. Lack of comfort with the topic of addiction medicine and having those conversations about, maybe I have concerns about a patient, and being able to have those conversations in a way that are non-confrontational and non-threatening, but yet still are healthy and have boundaries. And those are things that we as healthcare providers weren't trained to do. The imbalance of power. It's one of the conversations I had earlier today about how as a healthcare provider, we have our white coats, we're in our home turf. All the power is balanced in our favor. And so when a patient comes in, there's this huge power imbalance. And that's very intimidating to a patient. Additionally, when a patient's coming in with chronic pain, there's a lot of fear and concern about how they present to us as the pain provider. Because getting discharged from a pain practice or being labeled of having a substance use disorder when you don't have one, it can have devastating effects on a patient's ability to receive appropriate care for their pain conditions. So recognize that there's a huge power and difference. Discharging patients instead of referring. So a lot of pain practitioners who I've spoken with over the years would say, well, if I find a patient who has a substance use disorder, I just discharge them. And our practice, I've received a lot of referrals from other pain docs who have sent their patients, who have discharged their patients. And my point is, instead of discharging the patient, don't kick the patient out, refer them to a specialist who can help them. Because if you just discharge a patient and you just kick them out without a referral anywhere, without any guidance, what happens is the patient will bounce back to their primary care doctor, they're going to bounce back to the ER, they're going to bounce to another pain doc, and the cycle is going to continue, and it's not helping you, it's not helping the patient, and it's certainly not helping the healthcare system and society. And then the last thing is, ask yourself, what are you afraid of, or what am I afraid of? And part of that is an important thing to answer, but without judgment. It's okay to not feel comfortable managing these patients. That's why you're sitting here watching this webinar, to start to learn how to do that. When we first started medicine, we didn't know any of this stuff, and it took time to get comfortable managing patients. This is just one more subject matter that you're going to master. Trust is the foundation of everything. So at the end of the day, when we talk about the physician-patient relationship, if you don't have trust, if a patient doesn't trust you, the probability is that the outcomes are not going to be as good. And oftentimes I'll have a patient who will ask me, they're like, well, what's the likelihood of this procedure giving me a good result? And I'll often talk with the patient and I'll say, well, the reality is that what I find, and this is just my experience, is that patients who genuinely want to get better tend to get better. Patients who do not want to get better tend not to get better. And that can even occur on an unconscious level. And my point about that is that our beliefs and our perspective matter. And the relationship and the trust that a patient has with me as a provider impacts their expectations and often their experience of how a procedure or a therapy will work. So in order to build trust with a patient in such little time, so I want to acknowledge it's really hard because we don't have much time, so we need to make the most of that minimal time we have with our patients, is be present, meaning show up, be present with the patient. Don't just sit there on your computer talking and not looking at the patient. Be there, be with them, listen, honesty, tell them the truth. I can't make promises that I'm going to get rid of all of your pain, but we're going to do the best we can and hopefully get it to a point where the pain is manageable and that you can go back to living a full life. I want you to be present in life, and that doesn't necessarily mean your pain's going to be zero. However, we're going to do our best to get you there. And when you have trust, you have rapport, you have a relationship. And when you have a relationship and a rapport and trust with your patient, that breeds hope. Hope that you can help them. And hope is what is necessary for healing. When patients lose all hope, the chance of them healing is really hard. So I often think about, I don't know how many of you out there golf. I actually don't. The windmill always gets me at the end. So, but I use the analogy of slicing into the woods when it comes to where we're at in medicine and when we are identifying addiction. And so right now, it's like when you slice into the woods in a golf swing, well, you actually, the ball ends up in the woods because of things we're doing even before we strike the ball. Our form, our stance, where the ball, then where the club hits the ball, all of that impacts where the ball goes. It's the same with addiction. So, but we're identifying addiction, the equivalent of when the ball is already in the woods. You're like, oh, you sliced into the woods, but we're identifying it when it's in the woods. And we're identifying addiction when it's at its most severe. Meaning when the progressive, severe opioid use disorder is when we're identifying these patients. Where what the goal should be for addiction is identifying it earlier and sooner, then actually predicting at-risk patients, and ultimately preventing the development of full-blown addiction in at-risk patients. So Nora Volkow and Thomas McClellan recently gave the term pre-addiction. And it's similar to the way when we talk about pre-diabetes. And pre-diabetes was developed to help support treatments to prevent progression to full diabetes. Because prior to these ICD-10 codes and the diagnosis for this, also people weren't getting insurance reimbursement or support in order to have medications and therapies that could prevent progression to full-blown diabetes. And what's wonderful about that is by applying this model to addiction as well, we can start to, one, help differentiate the progression of addictive disease, but also it helps to support a mechanism to help improve access to care and funding for therapies in patients who may not necessarily need inpatient treatment because of severe substance use disorders, but we can actually start to employ and support and pay for services and therapies that could prevent them from progressing to full-blown addictive disease. So what is addiction? I always like to quote Cookie Monster. So addiction is when one cookie is never enough. It's important to recognize what addiction is not. It's not caused by a moral deficiency. It's not lack of willpower. It doesn't just happen to poor people, and it doesn't discriminate. So I have addictive disease. I've been in recovery for 23 years. I was an IV opiate addict and every other substance that I could get my hands on when I was in my active disease. I'm educated. I grew up in a white middle-class family. It didn't matter. Addiction doesn't care. It doesn't care if you're rich or poor, smart, not smart, attractive, unattractive. It doesn't matter. Addictive disease can impact any socioeconomic class. Addiction is a brain disease. And the American Society of Addiction Medicine has defined addiction as a treatable chronic medical disease that involves complex interactions of the brain circuitry, genetics, the environment. It's a disorder in the reward center of the brain. And the important thing to remember is that prevention efforts and treatment are generally as successful as for those of other chronic diseases like diabetes, high blood pressure, asthma. We have the same success rates. So addiction is characterized by impaired control, meaning that I can't stop once I start, I can't stop. Craving is that urge, compulsive use, and continued use despite adverse consequences, meaning bad stuff happens and I keep doing it. It's also accompanied by denial and a dysfunctional emotional response. And so when I talk about denial, addiction's the only disease that tells you you don't have it. And that's really important. So when we think about addiction, it's like when I start, I can't stop. And when I stop, I can't stay stopped. And that's different from physical dependency. So again, addiction is a disease, is a disordered brain circuitry disease. In the reward center of the brain, the circuitry is broken. The off switch, I often say, is broken. So again, the brain doesn't care whether it's, food, sex, gambling, chocolate cake, cocaine, whiskey, work, shopping, exercise, internet. All of those can result in can be addictions. And we talk about chemical addictions, cocaine, opioids, alcohol, but then there are also process addictions, behavioral addictions like gambling, sex addiction, work addiction, exercise addiction. So how does one develop addiction? It doesn't happen in everyone. Not everyone who drinks alcohol becomes alcoholic. Not everyone who does cocaine becomes cocaine addicts. So how does that develop? Well, there's a large portion of genetic predisposition. And we've known for years and years that, for instance, alcoholism runs in families. There's a hereditary component. That doesn't mean that just because people in your family have addiction that you will definitely develop it, but it means that you have a higher risk than someone who has no family history. So the genetic predisposition increases your risk of developing addiction. There are epigenetic changes that occur, so that whole nature-nurture thing. We have experiences in our life that can impact our predisposition to developing addiction. Trauma, PTSD, adverse childhood experiences, all of those increase the likelihood of developing a substance use disorder. So families where the children are exposed, where they had physical abuse, emotional abuse, sexual abuse, and neglect as well, all of those increase the likelihood not just of developing a substance use disorder, but actually also developing chronic pain. And then you combine that with stress, with intense pressure, and then exposure to drugs or exposure to a behavior or something that enables them to change the way that they feel. And remember that often people with substance use disorders don't have healthy emotional coping skills. And so they move to a behavior or a drug to change how they feel, to regulate their nervous system, which is dysregulated in stressful situations. And then those people can and often will develop addiction. Some factors that are associated with it, a personal history of having addiction. If you've had addiction in the past, you have addiction. That's a high risk for someone. Family history, meaning parents, siblings, first-degree relatives that have a substance use history, increases that risk. Psychiatric diagnoses have an associated risk. We're talking major depression, anxiety, ADHD is one of the highest. They have, I believe, a 9-fold greater risk of developing a substance use disorder. And think about it, ADHD, it's an impulse disorder. It's a disorder of impulse control. So it makes sense. History of smoking, nicotine addiction is addiction, it's a drug. Again, trauma, aberrant drug-related behaviors, and age less than 30. So if you have a patient who's coming in and they're 25 years old and they're already on opioids for a chronic pain condition, that's a much higher risk of developing an addictive disease longer term. And again, I've just talked about how pain and trauma and depression and anxiety all impact and increase the likelihood of developing a substance use disorder later on. Adverse childhood experiences. So this ACEs is what they call it. It was a study that was done that had a 10 questionnaire that had a number of different questions, like if the person experienced as a child, if they experienced violence in the home, if someone in the home had spent time in jail, if one of the parents, if they witnessed abuse, if there were substance use disorders in the home. And basically the higher number of yeses on these questions was the higher likelihood of early morbidity and mortality. And they've expanded the ACEs study and have started to look at all different sorts of outcomes. And one of those outcomes was increased risk for substance use disorders later on. So let's talk about pain. Well, what is pain? Pain is an experience. It's not just a physical issue that causes damage to nerve tissue. Pain is an experience. It's physical, it's psychological, it's emotional, it's energetic, it's spiritual, it's all of those things. I'll often ask, has anyone ever had a broken heart? And most of us have. And if you haven't, then I'm sorry for you, because it gives perspective on things. But anyway, having a broken heart hurts. That kind of emotional pain actually hurts. But again, the way we experience pain isn't just the physical injury to tissue. It's how our brain processes that and what we tell ourselves about the pain. So we have what they call the biopsychosocial model of pain that talks about there are cultural differences on how we experience pain. There are some cultures where everyone is very stoic and you may be hurting, but there's no outward expression. And there's other cultures where pain is expressed intensely. And there's biological parts of it. Obviously you break your arm. Yeah, there's a physical part of pain, you've got nerve damage, but there's also the psychological part, catastrophizing, the fear that the pain's never going to go away, and all of the other feelings about loss of control and the ability to do what we used to do, so it impacts our self-esteem. So all of these factors increase how one experiences pain. So when we talk about trying to compare apples to apples is challenging sometimes. If someone has a broken arm or someone has a chronic pain condition like a herniated disc, someone may not have experienced much pain. Others may experience a tremendous amount of pain. Some of that can be physical, but the other part about it comes back to the patient's experience and their suffering caused by that. So when we talk about chronic pain and a substance use disorder, what's the common thing? Well, the overlapping experience is suffering. And oftentimes, I'm sure you've heard, pain is inevitable, suffering is optional. Well, I don't know necessarily if it's always optional, but it's something that we definitely experience and have control over changing. And so when we talk about chronic pain, there's suffering in that. And with addiction, there's also suffering. And the same emotional driver for both. Behind it all is fear. When we talk about chronic pain, there's this fear, this pain's never going to go away. It's always going to be like this. I'm never going to be able to escape this pain. With addiction, the fear is, I'm never going to be able to get it. I'm going to go through withdrawal. I can't stop using, but I'm throwing away my life. I'm going to lose my kids. I'm going to lose my family. I'm going to lose my job. And I don't know how to stop, and I don't know what to do, and I don't have control. All of this, it's all fear-driven. And the overlap between chronic pain and addiction is profound. There's stress, anxiety, depression, there's financial challenges, there's sleep disturbances. Both pain and addiction destroy our lives and they shrink your world. So you lose friends with chronic pain, people stop inviting me out because I've got chronic pain and I've got to leave early and I'm isolating. There's a lot of isolation that occurs both with substance use and with chronic pain. So I often tell chronic pain providers, when you're managing patients who may have a substance use disorder, remember you're managing, the overlap is really very similar, meaning that how you manage them is important. Once you recognize that they're driven by fear and their primary experience is suffering, you can work with those things in order to help address those the same. It's not these two separate creatures that you're dealing with. You're really dealing with an overlap that you do have more training than you realize in managing this. All right, that's great. So how do I know who's got a substance use disorder? How do I figure this out? It's gray. It's all gray. We're swimming in gray here. And the reason why is because addiction is a progressive, relapsing disease that is fatal if left untreated. But not everyone presents in knocking off a pharmacy, right? Or forging scripts, or coming in telling you that they ran out of their pills on day 7 out of 30 days. There's a subtlety in there, and there are oftentimes patients who you have that you probably didn't realize had a substance use disorder until 2 of their urine tests came back positive. It's not always as obvious as you may think. And so I had a colleague of mine call me up about a patient once. Said, I have an 80-year-old patient who tested positive for meth. I said, okay. I said, well, so I tested them again the next month, and they tested positive for meth again. And I sent it to a different lab, and it was a confirmatory drug test, and then they tested positive for meth again. I said, okay. And my colleague said, well, what do you think? I said, I think your patient's doing meth. And I reminded them, I'm like, this patient was 33 years old at Woodstock. Meaning that the people that we think are obvious who may have a substance use problem are not as obvious as you think. And after the 60s, where there was a lot of experience with drugs, not everyone dies from drug use. And so people can live a very, very long time and have an undiagnosed substance use disorder for decades. And so it's important to recognize addicts may not look, or patients with substance use disorders may not look like you think they look. So you need to look at the whole picture. You need to be present, okay? These are the important things here. Be present and listen. If you're not present, you're going to miss the subtle cues. And again, this is about you protecting not only your patients, but protecting your license. There's nothing worse than having a call from the coroner because one of your patients is dead from an overdose and your name's on the bottle. So you want to know and do the best that you can in order to protect your patient, which also protects you as well. Ask uncomfortable questions. It's like years ago, people in the 1950s, people were really uncomfortable about asking sexual history questions. And nowadays, everyone's comfortable asking about their sexual history and number of partners and gender and preference and STDs and all of that. Whereas people are still kind of uncomfortable about asking about substance use and drug use. Ask the uncomfortable questions in a non-judgmental way. Oftentimes I'll joke about it like, I don't care if you shoot heroin in your eyeball. Okay, left eyeball or right eyeball? Meaning, when I'm non-judgmental about how I ask my questions and the answers, patients feel more comfortable. I'm not here to judge a patient. I just need to know the information so I can help them as best as I can. Because if they don't tell you, you're not going to know and you can't help them. So whatever they tell you, okay, fine. It's information, and go on to the next question. Observe behaviors. It's the subtle things. Look at family members. The family members will often tell you what's going on or see the interaction with the family members if the patient's lying about something or not being entirely truthful about something. You can often look at a spouse or a partner or a caregiver or someone who's with them and look at their reactions as well. That can give you a lot of information. By the way, if a patient's family member tells you to stop prescribing for the patient because they're using it or abusing it, you need to listen. I'm not saying stop prescribing, but you need to investigate further. If a family member expresses concern, you need to really look at that. Now, there can be other dynamics and issues going on there, but it has to be investigated. Use both risk assessments and psych assessments and understand the limitations of them. Drug testing is an absolute necessity for good clinical care. If you're treating a patient with diabetes and you never checked their hemoglobin A1C and you kept on prescribing insulin, that would be considered malpractice by most. If you're prescribing a medication like an opioid in which one of the consequences or the adverse effects can be respiratory depression and death, and yet you're never drug testing the patient to see if they're compliant or to see if there's other things going on in there that could have interactions that can increase the likelihood of death, you're taking a huge risk with your patient and with your license. Check the prescription history. Every state has a prescription drug monitoring database. You need to check that. Actually, the Texas Medical Board requires that before prescribing a certain controlled substances. Again, talk with family members and caregivers, and talk with other providers. So if a patient has, oftentimes I'll see a patient and they've already seen one or two other pain docs, I'll call them up and be like, hey, what's going on? Because that information can be helpful. I don't let it completely color or bias it, but the more information I can have about my patient, the better. Especially because we only see snapshots of our patients. We see them when they show up, and how they show up is a certain way that may not be how they are the rest of the time. So what's actually going on with our patient? It's not just, it used to be that the patient they either had a physical problem or, well, they've got a psychological problem. And somehow people used to separate those two, and they would just send them to psychiatry if they couldn't find a physical cause. That's not how it is. You can have chronic pain without any psych issues or addiction issues. A patient can present with chronic pain as well as psych issues, but without a substance use disorder. They can have chronic pain and an active addiction, or you can have patients who present like they have chronic pain, but they really only have active addiction. Or you could have a patient who has a chronic pain condition, but they're actually in recovery. So understanding what's actually going on with your patient is really that first step in figuring out how to manage them. So think in terms of risk, not certainty. And what I mean by that is, think about our patients of being at risk for a substance use disorder, not they either have a substance use disorder or they don't have a substance use disorder. I know a lot of providers will do our risk assessments like, the SOAP or the drug abuse screening questionnaire or the CAGE questions. We'll do all those on that first initial visit and then never, ever look back again. And we can have these patients for 5, 10 years. And what you don't realize is that oftentimes patients can be doing fine for a long period of time, and then something happens. They lose a job, they get divorced, they have a child, they move. So there can be a life stressor that tips them over that edge, and where they were doing fine, suddenly they're now abusing their medications and progressing towards active addiction. So think about risk, not the black and white, they either have it or they don't. Be present and listen. So after this, at some point in time in the next week, I want you to go in your office and with one of your patients, sit down, walk in, and for 30 seconds to a minute, just sit down, shut up, look them in the eye, and listen. It's really important because studies have shown even that when we sit down and when we listen to our patients, even for the study I think was for they would listen for 2 minutes, and then they would ask the patients later on what their experience of how long the doctor spent with them. And the experience was that the provider spent 15 minutes with them. So again, it's about perception. If you sit down eye to eye, hey, tell me what's going on, and just listen. You don't have to respond, you don't have to fix it. Just listen for 30 seconds to a minute. That completely changes the patient's perception of your presence with them. And quite honestly, it helps you focus on your patient and really hear things that you need to hear. Talk with family and caregivers. Like I was just saying, they're going to tell you things that your patient is not going to tell you. Behaviors are your breadcrumbs. Look at the way patients behave. Do they always make their appointments for their refills, but they, for whatever reason, aren't able to show up for their procedures or for the days or their appointments where they don't have a refill? Do they cancel on their behavioral health appointments but always make it in time for the other appointments? Look at your patient's behavior, how many times they call. All of those things give you an indication of what's going on with your patient that they're not telling you. So I want to talk about the difference between physical dependence and addiction. And that's important because a lot of times I'll have patients who believe they are addicted, but they're really only physically dependent. And then I have other patients who believe they're really only physically dependent, but they actually have addictive disease, a substance use disorder. And I use the terms addiction and substance use disorder somewhat interchangeably in this webinar. If you haven't figured that out yet, work with me on that. So with physical dependence, the patients are results focused. Hey doc, look, if you tell me to stand on my head, I'll stand on my head. I just need to get out of this pain. Where addiction and substance use disorders tend to be drug focused. Doc, look, nothing else works. I've tried everything, nothing works. Well, what about no, that's not gonna work. That's not gonna work. Only the hydrocodones work, or only this works. They're more drug focused. Physical dependence may or may not have risk factors. There are multiple risk factors with addiction, like we talked about, with genetics, history of trauma, those kind of things. The patient who has physical dependence, they're open to different types of therapies to address their pain. Again, doc, I don't care what we do. I don't care if it's medication. I don't care if it's an injection. I don't care if it's physical therapy or psychological. You tell me what we need to do to get me out of this pain, and I'm good to go. I'm in. Versus someone who has a substance use disorder, they're not going to want to do these other therapies. They may reluctantly, look, if I do these injections, will you write me for my hydrocodone? That kind of thing. Or nothing else works. The only thing that works are oxycodone, or the only thing that works is, whatever their preferred drug of choice is. When I hear nothing works but ... and whatever that ... is a controlled substance, that's an indication that I may be dealing with a substance use disorder. Most of the time, patients who may have physical dependence, meaning that they've been on chronic opioids for a long time and their body is physically dependent on it, but they're not experiencing cravings or impulse control problems. They can stop, but they go into withdrawal. So it may look similar, but oftentimes they're open to do whatever. And sometimes I'll have patients be like, doc, I'm addicted to hydrocodone, you gotta get me off of this, but I still need you to manage my pain. That's important. And they're consistent. And patients with physical dependence, they're consistent. They show up when they're supposed to show up. They make their appointments. Their drug tests are consistent. Their prescription drug monitoring reports are consistent. There's no unexpected behaviors or unexpected results. Oftentimes with patients with a substance use disorder, you're going to have inconsistent or unexpected results on drug testing, meaning the drug that you're prescribing may not be present when you drug test them because they may have used them up too soon, and then they show up and their urine is negative for it. Or the prescription drug database report may be inconsistent. I didn't know you went to the emergency room and got tramadol or another medication. I didn't know you went to this other doctor, and oftentimes it'll be dentists. I forgot to tell you, so those things are all indicators. Again, think risk, not certainty. The more things that fit in the column on the right increase my suspicion of a possible substance use disorder. And then if the pain is managed, the behaviors stop. Whereas with addiction, the behaviors don't change regardless of how much medication we're prescribing. And it's important because oftentimes I'll hear patients say, look, doc, if you just managed my pain, I wouldn't be taking all of this pain medicine, in 2 weeks. That's not what I'm talking about. What I'm talking about is that you take a multimodal approach in managing your patient's pain, and their pain gets better. You may not actually have increased their opioids, but their pain still is improving. They're moving or trending in the right direction, and so some of those behaviors stop. If you increase or escalate a patient's opioids and the behaviors don't change, the solution isn't to continually increase the opioids. Because if you keep increasing opioids and the behavior and the complaint of pain doesn't change, in any other thing, if I keep prescribing a medication for high blood pressure and I keep escalating that medication and the blood pressure still stays high, maybe I need to change medications. It's the same thing here. If you try to escalate opioids to manage pain and there's still pain and a lot of it, or it doesn't change the amount, you need to think about other things. So what I'm talking about here in manipulations are ways that patients, and again, these are indicators or clues that your patient may have a substance use issue. So bullying, let me put it this way. When it comes to manipulations, patients will use whatever assets they have in order to get what they think they need. And so early on in my career, we had these patients who would present, and we had different, about 9 different ways that certain patients would present. We had like the little old lady who was very, very frail and would present that way. We had patients who could cry at will. We had the single dad. Hey, look, I got to be on these medications for the rest of my life. The last doc said I'm going to be on these the rest of my life, and I don't really want to, but I'm okay with that. And I would go, well, no, really, we can get you off of these medications. And they'll be like, oh, well, no, I can't really get off of them either, because I'm a single dad. And I never really understood the whole single dad part, but, I got to keep working, and therefore I need these medicines, even though a moment ago they said they didn't want to be on them. So there's all different kinds of ways that people will use what they have, bullying, seduction, tears, threats of self-harm. If you don't prescribe for me, I had a patient once who said, well, if you're not going to prescribe methadone for me, you're going to make me buy them on the street. And so I politely corrected them and say, no, I'm not making you buy them on the street. I've given you multiple options to manage your pain, but none of them included methadone. And so that's really important. The threats to report you to the board, at a recent talk I did, a large number of people in the audience had at some point in their time had a patient who threatened to report them to the board or the DEA or their insurance or someone for not prescribing. Don't give in to threats. Parents with adult children, or caregivers who will talk over the patient. And that actually can happen sometimes with elder abuse, where we'll have a son or a daughter come in with the patient, but the patient doesn't speak, and the son or daughter will constantly jump in, and those are things that you want to worry about. Comrades in healthcare, where we get healthcare providers with a substance use disorder, and it's all about the connection and the manipulation. These are all manipulations. The VIPs, I'll report you to the board, all of those things are manipulations to try and get us to prescribe something. So, high probability of patients with a substance use disorder. Obviously, if a patient tells you they have a substance use disorder, believe them. They have a substance use disorder. All right? That's a slam dunk. A forged prescription. This category I call the duh category. Like, these are just, if you miss this one, I'm concerned about you. But if a patient tells you they have a substance use disorder, they do. If they forge a prescription, less likely these days with electronic scripts, but nonetheless. If they're intoxicated at the visit, they're sitting there and you're talking with them, and in mid-sentence, not off. When a patient falls asleep in mid-sentence in front of you, that's an issue. Track marks, overdose. One of the challenges that we get in healthcare right now is that there's not a lot of overdose reporting that gets back to the prescribing provider. And I know a number of states have started to institute tracking and logging overdoses so that we know. There was a study done a number of years ago that showed 91% of patients who overdosed on an opioid got another script for an opioid after that overdose. And that's not necessarily lack of care by the provider, but rather lack of awareness that an overdose occurred. So there's a lot of things that are happening now to try and improve the communication if a patient does have an overdose. So stronger indicators of a substance use disorder. Again, when a family has a concern about the patient, if they're calling up multiple early refills every month, they're always asking for a refill sooner, a week early, 2 weeks early, negative urine tests, or an unexpected urine result, and there's not an appropriate, legitimate explanation for that. They admit to using street drugs. When patients come in, we're seeing patients now coming in saying that they're using kratom to manage their pain. Most people don't know where to get kratom. And most people, when they have chronic pain, they're going to go to their provider rather than go buy them on the street. So that's something to be concerned about. Multiple DUIs, absolutely huge indicator of a substance use problem. So, opioid risk assessment tools, and those are often part of requirements by payers and for good care to assess the risk of the patient. be cautious about these. They provide some information, and I find that there's multiple risk tools that you can use. I'm not going to say which are the best or the worst, because all of them have significant limitations, meaning that any good addict worth their weight in salt who knows that they have an addiction problem can beat those screening tests. I know how to answer those in a way that doesn't indicate that I have a substance use problem. And most seasoned patients with substance use problems know how to answer those. These risk assessment tools are great for a patient with a substance use problem who doesn't know they have a substance use problem. They just think it's normal. I had a patient once who actually a young patient in liver failure who drank 50 beers a day and didn't realize it wasn't normal because everyone in the village where they came from drank that much. It was totally normal to drink 50 beers a day. And so they didn't even know that was not normal. So some of these risk tools are great to capture and identify. I take that back, I did not mean capture. To identify patients with a substance use disorder who don't know they have them, but you can't rely on these, or you need to acknowledge the limitation of these in a seasoned substance use disorder patient who knows they have one. Use it as a data point along with all the other clinical assessments, urine drug testing, the PDMP. Use it all together to really get a picture of what's going on with your patient. Psychological assessment tools are really important as well, because if a patient has anxiety, depression, or other psychiatric issues going on, and you don't treat them, it worsens, it increases the likelihood their pain will not get better, and it increases the likelihood that they would have a substance use problem. So the ones that I listed are just an example. There's a lot of psychological assessment tools out there. What's important, and the takeaway from this, is when you're using these psychological assessment tools and they're positive, refer the patient for the help that they need. In my own practice, I had included behavioral health practitioners in my practice. And what we found is that helped patient, whether or not they had a substance use disorder or not, it helped them improve their pain, because it helps them with, again, that pain experience. So helping patients learn how to reframe their pain experience is really significant as well. Remote patient monitoring, and this is something that has been covered by CMS for the last couple of years, and that's really to look at a lot of the newer technologies out there that help us get an assessment of what's going on with our patients when they're not in our office. And again, more research is needed to assess the relationship of these technologies to patient outcomes. It's still relatively new and we're still gathering data, but it's important that I mention that between physiologic wearable data as well as medication adherence technologies and behavioral data as well, that gives us a snapshot of what's going on with our patient when they're not in our office. Location tracking and telehealth services are also really helpful. So these are, again, more data points that help you round out your total clinical picture of your patient. So drug testing saves lives. My point about this, and again, I've already said it before, if you're prescribing controlled substances to your patient, you need to be drug testing them. You don't drug test them every day, folks, okay? But you need to drug test them appropriately to make sure that, one, that they are taking their medications. Number two, you want to know if they're not taking their medications and why. And then it gives you an opportunity that at times you can potentially identify someone with a substance use disorder before they get in a car crash, before they overdose. This is a way that you help your patient stay safe, you help you stay safe from a medical legal perspective, but also it's important because it helps support those patients that are compliant with your treatment plan. And that's also important. So it's not just about identifying someone who has a problem with substances or diverting, but it also helps to document and support patients who are appropriate. check the prescription drug monitoring report in your state. And again, that's a requirement before prescribing, but it's always good on all our new patients, we check it regardless. Because even if you go, well, I'm not prescribing for this patient, I'm not prescribing any controlled substances. Well, your patient can still have a substance use disorder. Alcoholism is the most common of the abused substances that people are using, and it's legal. But they can still have an alcohol use disorder that can be threatening their lives. And as a doctor, I want to know that, even if I'm not prescribing opioids for that patient or benzos for that patient. Because if they are having a problem, I can get them help. And then that can actually potentially save their life, even though I'm not prescribing any controlled substances. Talk with other providers. Again, if a patient's, talk with the referring doc. Hey, what are your concerns? Has there been any other issues? Sometimes it's a primary care doc who's seen this patient for years and years and years, and they can give you information. Sometimes it's another doc who may have discharged that patient from the practice, and often I've had patients who say, well, my doctor moved away. So we'd call up the doc, and the doc's like, no, we didn't move away. And actually, in one time, the doctor moved away. So it's important to follow up. We have a duty to follow up on these things, and providers can, and this is under the umbrella of HIPAA because it's about providing this patient's care. All right, you should probably stop and go get a cup of coffee or something. All right, but I'll keep going. All right, now what? Clinical management pros. Okay, so I've identified someone who has a substance use disorder and they have chronic pain. Okay, what do I do now? Well, the first thing that you want to do is you want to think about common goals and shared decision making. One of the biggest problems that we get within, especially with chronic pain, is patients lose their autonomy. Their world shrinks. They can't do the things they used to do. Oftentimes, the self-esteem is really hammered because I can't do the things that I used to be able to do. I want to show up as a husband or a spouse. I want to, and now I can't do those things because I hurt. I don't go out with my friends because I hurt, and suddenly their world shrinks. And so when we talk about autonomy and shared decision-making, including a patient in the decision-making of the treatment plan gives them some control in a life in which they don't have a lot of control. And that has a huge therapeutic effect. So, what are the goals? Well, I want to decrease the patient's suffering, okay, and the impact on their life. Ideally, I'd love to get every patient to a pain level of 0. That's fabulous. But that's not always possible. So I want to help decrease their experience of pain, decrease their suffering. If I can't eliminate their pain, I want to help them get back to life as best as they can. As a provider, we want to know enough about substance use disorders so we can engage our patients confidently. It's why you're sitting here watching this webinar. We validate patients' feelings. Validating a patient's feelings doesn't mean that everything, their perception of what's going on is factually correct. It may be, it may not be. That's not what we're talking about here. Everyone has a right to feel their feelings. By validating someone's feelings enables them to feel like you've heard them. So, Doc, I feel like it's never getting better and no one's listening to me and people don't care, and the last doc didn't care, and I'm just really angry and frustrated. Okay. I can understand how having the experiences you've had, how you would feel that way. I'm not telling them they're wrong, and I'm not telling them they're right. But if I had gone through that, I could see how I might feel that way. It's about validation, and it's about connection and rapport. Identify and address patients' beliefs that keep them stuck. And so oftentimes I'll try and understand what my patient tells themselves about their pain, because their beliefs create their reality. For instance, if there is a patient who blames themselves for something that happened to one of their children, and they feel guilty about that. Well, I wasn't there and I wasn't able to protect my child. And there's a guilt involved with that. And they've got a pain problem, and the pain happened to start right around that same time. That's one of those things where you have to address the core belief in order to help the patient move through the pain. You can treat the physical parts of pain, but if we also don't manage the beliefs that keep that pain alive, then we're not going to be successful long term with that patient. And what I mean by that, if someone feels they deserve to suffer, the probability of us being able to stop the physical pain is unlikely. But if we can address and help them reframe their beliefs that whatever the issue was, helping them work through it, that can also help address their pain. And I had a patient once who presented with headaches, and I asked, well, how old were you when the headaches started? I was 5 years old. Okay, well, what happened when you were 5? Did you have any physical abuse, emotional abuse, sexual abuse? And the patient said, well, I had some sexual abuse. And I said, okay, did you ever address that? Did you ever do therapy? Was it ever dealt with? And the patient said, no, it wasn't. And so I had a conversation with this patient about, well, I could do a couple of things to address the headaches, but the probability of any of them being successful long term is unlikely, given the timing of the onset of these headaches at exactly the same time that they were occurring with this abuse. And the patient said, I don't want to address any of this. I don't want to talk to a therapist. I don't want to deal with this. I just want that. And so I had to be lovingly direct and honest that I could do all these things and that may help, but that pain, the patient had physicalized the trauma. And addressing that, the trauma is also part of the key to addressing the pain in general. So helping identify those beliefs and helping patients change those or reframe those beliefs can improve the results of their pain. So other common goals are to improve the patient's physical and emotional coping skills. So the better patients have the ability to cope with uncertainty and to cope with fear, anxiety in a healthy way, the better that they will be in coping with pain, as well as decrease their risk of turning to substances in order to handle those uncomfortable feelings. We want to decrease reliance on pain medication. Although pain medications can be a very appropriate part of a multimodal pain management program with a patient, we want to decrease the idea and the belief that the only way to manage my pain are these pills. We want patients to understand that there's a multitude of therapeutic interventions that we can do, both physical and psychological and behavioral, that can all help in addition to medications as well. We want to minimize the risk for addiction and relapse. So in patients who are in recovery who have chronic pain, they don't want to relapse any more than you don't want them to relapse. So the goal is, how do we manage their pain in a way while minimizing the risk of relapse? And for those patients who don't yet have a substance use disorder, or those patients who are at risk for a substance use disorder, we want to minimize the risk of them developing one. So one of the patient populations that I see sometimes are those where I'll be talking with a patient and I'll ask them about their own personal history of alcohol or drug use. And they're like, no, I don't drink, I don't use drugs, I don't smoke, I've never done drugs, I don't drink alcohol. And I'll always ask them, why? Most people in American society drink alcohol at least once in a while. So normally a couple of reasons why patients often don't is either religious reasons, health reasons, or a history of substance use. And sometimes though, I'll have a patient who will say, well, my mom or my dad, one of my parents or someone in my family had an alcohol or a drug problem and it was a disaster, and so I've never done it and I never will. And it's important though to have a conversation with a patient like that they still have the genetic risks. And sometimes you can get iatrogenic substance use disorders by exposure. So those are patients where I have that conversation with them about, hey, look, if we do prescribe opioids for chronic pain or other medications that could have a substance use thing, there's still that risk. And that's really important, because if they do develop a substance use disorder and they weren't really aware of it, or we as a provider don't think about it because a patient says, well, I've never done drugs and I don't drink and I don't smoke. Well, on a surface level, it sounds like they're fine and they're totally low risk, but they may not be low risk because of the genetic component. And that's an important thing to realize. And then developing support networks, not just for the patient, but also for the care team. So, and what I mean by that is, you may not be an expert in managing substance use disorders. You may be absolutely amazing pain physician or a healthcare provider managing pain. But here's another area where you're not. Or you may be an amazing addiction medicine provider or a therapist in dealing with substance use disorders. And fantastic, but you're not comfortable with pain. Communicate with each other, talk to one another. Pain docs can teach addiction providers about pain. Addiction providers can teach pain practitioners about addiction. So you want a support network as well. What's interesting is that there's huge support networks out there for patients with substance use disorders. Alcoholics Anonymous has been around since 1934. There's all these different 12-step groups. There are also other recovery type groups that are non-12-step based. There's tons of support and meetings all around the world for substance use disorders and other behavioral addictions. There's only recently started to develop support groups for chronic pain patients. So many chronic pain patients have been in isolation. And then for patients with both chronic pain and substance use disorders, it's really challenging because a lot of the recovery groups don't support any kind of medication. So creating support networks for chronic pain patients with or without substance use disorders is really important. All right, awesome. I think I got it. I'm in. Let's treat them. Well, appropriate management of a patient with a chronic pain and substance use disorders, this is just not the way to do it, okay? This is not the correct way to manage them. The key point to remember is, in patients with both chronic pain and a substance use disorder, you must treat both. If you only treat the substance use disorder, the pain's going to get worse. And if you only treat the pain, the substance use disorder gets worse. You have to treat both concurrently. So this is the way that I practice as I'm making decisions on patients. Keep it simple. What's best for the patient, and what will I say on the stand? And generally speaking, if I do what's best for the patient, I'm fine saying the same thing on the stand. And that is just a general guideline. Again, think about risk-benefit ratio. If the risks outweigh the benefits, it's probably not a good idea. If the benefits outweigh the risks, then it may be a good idea. But either way, make sure you document that. So in this patient with these conditions, it was appropriate to prescribe opioids, even though I'm aware the patient has a substance use disorder. But in this pain condition, I understand the risks, but in this patient, in this situation, the benefits outweighed that. Or vice versa. In this patient with this pain condition, the risks associated with opioid prescribing outweigh any possible benefits, and therefore it was discussed with the patient that I would not be prescribing because the risks outweigh the benefits. So when you're managing patients with chronic pain and substance use disorders, think multimodal and multidisciplinary, right? So you want to address physical therapies, pharmaceutical therapies, interventional and procedural therapies, complementary and alternative therapies. Hypnotherapy is another one, psychological therapies and behavioral health support. Utilizing all of these factors together help to manage all different aspects of the pain experience. And that may include addiction treatment. If you've got someone with active addiction, they may need inpatient treatment, and then you can manage their pain in the addiction treatment facility or in conjunction with the addiction treatment facility. Relapse prevention can be a part of that, as well as lifestyle changes. All of those factors play into it. And most likely, most of you are not an expert in all of these things, and nor would we expect you to. This is where that team approach comes in. So you want to treat the physical aspects of pain, right? I mean, you have a herniated disc, or you've got joint dysfunction, or arthritis. You want to manage the physical parts of the pain. You also want to manage the psychological and the emotional aspects of pain. You know, when there's anxiety and depression that are impacting their experience of pain and making it worse. You know, people can have pain and it can be their whole world, or it can still be there and the pain sucks and I don't like it, but it just has a little bit of awareness, but I still have the rest of my life around me despite having pain. So really helping patients reframe how much control pain has over them is important. And you must balance pain management and addiction risk. And that balance shifts at times depending on what's going on with the patient. Again, a patient can be doing fine for a long period of time and then something happens that may not be related to their pain, but something can happen in their life that impacts their coping skills, and suddenly they start to overuse their medications. And that's where we want to be present and understand when our patients' use changes. So when we talk about boundaries, not walls, okay? Boundaries are limits in which I'm comfortable in how I'm managing the patient, because when I go over those boundaries, then I put the patient at risk and I put myself at risk. Boundaries are like a door or a gate. They open in certain situations and they stay closed in other situations, depending. It's not a wall. So I had met someone who said they do chronic pain and addiction, and I said, well, that's great, that's wonderful, we need more providers. And they go, yeah, I never prescribe opioids. And I looked at them. And what that told me was that never prescribing opioids for any chronic pain patient out of fear of addiction means that you don't understand addiction. Because, and I've often said this, that, you know, I'm subject matter expert in chronic pain and addiction. I'm boarded in pain, I'm boarded in addiction. I'm in recovery for 23 years, and I prescribe opioids to an appropriate patients with appropriate conditions. And when it's not appropriate, I don't. And the key, and what makes us experts in both, is that we know when it's appropriate and when it's not. And that's part of what this webinar is helping to educate you with. It's not a wall, it's a door, it's a boundary, where in some patients I would prescribe because in that patient, in that situation, it's appropriate. In others, I won't. So a good example of a boundary is the patient that I talked about who said that I would be forced, if I didn't prescribe methadone for them, that they would go out on the street and get it. My boundary was I will come up with all these different therapies to help manage your musculoskeletal pain, but methadone is not one of them. That was my boundary. Now in another patient, the patient had a pain condition that was appropriate for opioids, for the short-term use of opioids, and we did it. And that was okay, despite there were some risks as well, and we talked about those. So that's really important, is knowing where you stand. If the manipulation pushes you to be doing something that you're not comfortable with, that means that's sort of a signal to you that your boundaries are being crossed. Okay, and patients will push boundaries. It's my responsibility as a provider to hold my boundaries with what I feel is safe for the patient and appropriate for the patient. Know your limits. So, like I said in the beginning, no one is expecting you to become an overnight addiction medicine expert. You need to know the basics, but it's important to recognize that you're not going to know it all. And at that point, be willing to refer or to ask for help. Be willing to call up an addiction provider and say, hey, look, I've got this patient and they're saying this and they're saying this, and what do you think? And get some feedback. We don't have to do this alone. We don't have to treat these patients alone. We can ask for help, and it's important to do that because that's what makes us better providers, and it helps our patients. Again, eliminating opioids is not the solution. But let me be clear, I am not saying that prescribing opioids for everyone is the solution either, okay? Again, we're back in the gray. There are certain patients and certain pain conditions where it's appropriate and others where it's not. And that's, so again, keeping it simple, I ask myself, is this pain appropriate for opioids? Patients coming in with fibromyalgia or musculoskeletal pain, the pain is not appropriate for opiates, regardless of whether the patient is or not. The first question is the pain even appropriate for me to prescribe opioids for at all? And if the answer is yes, the pain is appropriate to prescribe opioids, then my next question is, well, okay, is this patient appropriate for opioids? Right? And that goes back to risk assessment and the degree of risk. And again, the pain may be appropriate, but the patient may not be appropriate. And so in those situations, I wouldn't. But if the pain is appropriate for opioids and the patient is appropriate for opioids, and there are reasons and other things have failed, again, opioids are not your first line choice. But when other things have failed, or if it's part of a multimodal thing, it's something to think about, but you have to answer these questions first. So there's been a lot of talk about buprenorphine. And buprenorphine has been used both in pain management and it's been used to help treat opioid withdrawal symptoms. And buprenorphine is an opioid. It's a partial agonist, antagonist. It's a partial agonist at the mu receptor and antagonist at the kappa. And it's important, though, to remember that buprenorphine is not a complete pain management program for patients with chronic pain and addiction. But I want to be clear about this. It's a great medication. It has revolutionized a lot of what's gone on with addiction treatment. And it has a role in both chronic pain and in addiction. I want to be clear about that. I prescribe buprenorphine in my own practice, and I think that it plays a great role. But it's not the only solution out there. It's important to understand that it is abusable, it is diverted. A patient can overdose and die on it, even though there's a decreased respiratory depression. If a patient mixes it with other CNS depressants, you can still have an overdose. There are case reports of this. So my point about this slide is not to say that buprenorphine isn't good. It is good, it's great, and it has a very important role both in substance use disorders as well as in chronic pain. But it's also important to understand its risks and how it's used as part of a multimodal treatment program. That being said, pain management is much more than just pills. So there's all different types of pain therapies out there where sometimes people think that pain management is just pills. No, there's physical therapies like interventions, there are physical therapy, occupational therapy, massage therapy, somatic therapy. There's pharmaceutical, there's all different kinds of medications that go far beyond opioids. There's anti-inflammatories, there's anti-neuropathic agents. There's a slew of different medications that impact different pain areas. Psychological therapy, behavioral health therapies, there's alternative and complementary. There are interventional procedures like injections, epidural steroid injections, nerve ablations. There's also surgical interventions. So there are certain pain conditions that require surgery, like a disc removal or a fusion. And again, there's what I call electrical therapies, which are like a spinal cord stimulator or a peripheral nerve stimulator. So there's all of these different types of therapeutic modalities that when you use all together can create those options. And this is important when you're talking to your patients about their pain, especially if you're choosing not to prescribe an opioid for their pain and they say, well, how are you going to treat my pain? Well, this is the slide where you go, well, there's all these other options that we use together to manage all the different aspects of your pain. There's physical therapy. There's other medications we can use. If you need to, we can do surgery, but we want to hold off on that if it's not necessary. There are other interventions that we can do. And so offering your patient solutions when they ask you that question, well, if you're not going to prescribe for me, how are you going to manage my pain? It's important you have an answer for that. But what about weed? It's natural. So we are now in the era of marijuana legalization. For the record, the DEA federally still considers marijuana a Schedule I drug. So how you prescribe in your state is however you choose to prescribe is your professional decision, but understand that the federal DEA still considers it a Schedule I substance. Now again, hemlock is natural, but I'm not going to go make a big cup of tea and drink that. So the way that I look at marijuana in general, so marijuana is a drug with psychoactive properties, like many of the medications that we use. And safety and efficacy have nothing to do with whether a drug is synthetically derived or naturally made, okay? That's the bottom line. So the way that I look at marijuana is I view marijuana exactly as I view any other potentially abusable substance. Is the patient appropriate for this, right? Is the pain appropriate for marijuana? And is the patient appropriate? There are patients who have addictive disease and the only drug of choice they have is marijuana. There are some that use marijuana socially and recreationally and don't have a problem with it, just like alcohol. But not every patient is like that. So opioids, when used appropriately, are great medications. When they're used in the wrong patient or for the wrong reasons, they're not. Marijuana is the same thing. So I've often had patients say, well, and this was back when marijuana was illegal all across the board. And I have a patient say, well, I use marijuana and I use it for my pain. And I'm like, and I'll ask them, well, does it help with your pain? And they'll go, yeah, it does. Hey, awesome. That's great. You found something to help manage your pain. I have no control over what a patient does, whether they buy marijuana or smoke marijuana. I don't have any control over that. But all right, well, if it's managing your pain, that's awesome. I'm glad you found something. Well, we have all these other solutions that we have, but I can't necessarily prescribe opioids for you if you're buying marijuana on the street. And sometimes patients will stop smoking marijuana, and that's again where drug testing is important, because the PDMP doesn't track anything you buy on the street. So again, I view any of these medications that we use that are potentially abusable, whether they're opioids or benzos or marijuana or barbiturates, they all have abuse potential. And you're hearing a siren right now. Who knows? That could be an overdose right there. But it may not be. I don't know. The point being that manage any potentially abusable substance, it's really about making sure that the patient's appropriate and the condition is appropriate for whatever they're using. And if you prescribe opioids, prescribe naloxone. And for those who may not be aware, naloxone is a pure mu antagonist. It is a competitive blocker for the opioid receptor, the mu receptor. So what it does is it reverses opioid overdoses. Okay? So anytime you're prescribing opioids to a patient, you want to prescribe naloxone to have available at home in case they have an inadvertent overdose. So it's important to remember that when we're talking about opioid overdoses and appropriate patients, not every patient is inappropriate for opioids because of a substance use risk. There's a lot of patients with cognitive dysfunction. When I have a patient who tells me about their memory problems, oh, I can't remember anything. Well, then you're probably not an appropriate patient for an opioid, because if you can't remember if you took it or not, and then you take another one, and you can't remember if you took that one, so you take another one. Next thing you know, you've got a patient who's at risk for an overdose, even though they may not be at risk for a substance use disorder. Patients that are on benzodiazepines, well, what's one of the major side effects of benzodiazepines is anterograde amnesia. You don't remember. So if a patient's on a medication like a benzo or some of the Z drugs like zolpidem, then they're going to have memory issues. So adding opioids on top of that could increase the probability for an overdose. Naloxone can reverse opioids and it can save a life, so prescribe that. And just so you know, naloxone actually is now available over the counter without a prescription. So even if you choose not to prescribe it for them, tell your patients that if you're prescribing for them, they need to go and purchase naloxone at their local pharmacy or drugstore. It is over the counter now. I was actually part of the FDA advisory committee that got that out and over the counter because we need to. That can save lives, especially if a family member is around. So as a general rule, opioids and alcohol don't mix well. Legal doesn't mean safe. And my point being that a lot of patients with chronic pain may not admit that they still drink alcohol. Most of the opioid contracts and pain management practices stipulate you should not be drinking alcohol on these medications or any CNS depressants while with opioids. So you get a synergistic effect, which increases the risk of overdose. Okay? So alcohol is one of those big ones. The same goes for benzos and Z drugs. Again, like I was saying, when you're mixing them together, you get a synergistic effect, which increases the risk of overdose. So as a rule, clinically, I don't prescribe benzos because I don't use benzos for pain management. However, I have patients who are getting prescribed benzos and Z drugs by other providers, and I have to make a decision about whether or not they're appropriate if I'm going to prescribe an opioid or not prescribe an opioid. So it's a dangerous combination, and I suggest avoiding it. So let's say you want to discharge the patient. You're not comfortable managing this patient, or the patient has displayed enough behaviors that at this point you can't manage them effectively and you need to discharge. Well, how do we do it appropriately? Again, and I've said this before, if you must say goodbye to the patient, refer them, don't just discharge them. And what that means, how do we do it the right way? Well, and when I say doing it the right way, I mean discharging a patient in a way that is legally compliant and appropriate. Having a patient leave the office and then get a letter a day before or a phone call before their next appointment saying, "Oh, I'm sorry, you've been discharged." That's not the way to do it. Tell the patient in person. Give the patient resources. Refer them, if it's for a substance use disorder, refer them to a treatment facility or an addiction medicine provider. If no one's local, there's a lot of telemedicine for behavioral health, and that whole market is booming. So even if you're in a rural area, you can still refer the patient for an evaluation or an assessment for substance use disorder via telehealth. Referral resources, the Substance Abuse and Mental Health Administration has a behavioral health treatment services locator, and they also have a buprenorphine provider locator. Now again, it used to be that there was a requirement for a special DEA license to prescribe buprenorphine to patients with an opioid use disorder. That has been removed. As of this year, any healthcare provider with a DEA license can prescribe buprenorphine without needing a waiver or a special DEA license. So all of you can. All right, so summary. So how can I tell who has a substance use disorder? Look at the whole patient, okay? All these different data points, the risk assessment, the PDMP, the drug testing, the patient's answers, family members, providers, all of those little data points create a picture for you to evaluate your patient. So look at the whole patient. Be present and listen to your patient. And when I say be present, again, sit for 30 seconds when you first sit down with a patient. Look them in the eye, give them eye contact, and just shut up and listen. Let them be heard. And then you can start to talk about other things that you want to in terms of management. But listen, you want to develop a rapport with your patients. You want trust, even though you don't have a lot of time. That's going to have a huge impact on your outcomes, I believe. Use risk and psych assessments, but know their limits. They're really good to give you as screening tools, but they're not diagnosis tools. And so again, use them as data points. If a patient needs a substance use disorder assessment, refer them for an assessment if you're not an expert in that area. And then talk with that provider, because they can teach you about substance use issues and you can teach them about pain. Drug testing, prescription drug monitoring, history checks, and consider remote therapeutic monitoring and remote physiologic monitoring. So what do I do once I know my chronic pain patient has a substance use disorder? Again, if you need to make a decision if you want to continue caring for that patient. If not, you want to discharge appropriately and refer. But if you decide to continue to treat the patient, keep it simple. What's best for the patient? What will I say on the stand? It's that simple. And again, if you're going to prescribe or not prescribe, that's your clinical decision that you base on that patient in that situation. Again, is the pain appropriate for opioids? And is the patient appropriate? If the answer is no to either one of them, then the risks outweigh the benefits. Multimodal pain management. Always think multimodal, different physical therapy, psychological and behavioral health therapies, pharmaceutical, interventional, alternative and complementary therapies. All of those factors play into it. Electrical therapy and surgery if necessary. Be present, connect with your patient. Build trust in a relationship, because that leads to hope and hope leads to healing. Those are really, really vital for the long-term outcomes of your patients. And it also can decrease your medical legal risk as well. Again, if you feel you must discharge a patient, refer them and then discharge them appropriately. Also, document. Everything that you do, make sure that you document, because as we know, if you didn't document, it didn't happen. This is important for you to support your decisions that you're making and to support appropriate patients for continuing to provide therapy. But at the same time, it's also appropriate if you do discharge or refer a patient out, that you document the reasons why. It's good patient care, it's medical legally smart, and it's compliant. So don't give up. I know this was a lot and we covered a whole bunch today. Keep watching other webinars, keep doing research, talk to other providers that aren't in your specialty that can help you and you can help them. But don't give up. Effectively addressing chronic pain and addiction together, it can be doable. It's challenging, but the reality is they're in all of our practices. And the better you get at doing it, it actually becomes easier and easier. And at the end of the day, you may be the only shining light that your patient ever sees. And that really makes a huge difference. So thank you very much. Again, if you have questions or comments or I can help in any way, please feel free to reach out to me. My email is michael@drsprintz.com, and you can reach me at www.drsprintz.com. Thanks very much for watching.